Good day to our dear clients and patients here in CMI. So I'm deeply honored to share with you a topic close to my heart. No? So I am Dr. Jereel Aron Sahagun. I am an internist endocrinologist. I deal with diabetes, thyroid, and other hormonal disorders. So aside from diabetes and thyroid and other hormonal disorders, today I was tasked to share with you a very important topic nowadays. No? So let's talk about obesity and weight management. So let's first define what is obesity. It's a condition of abnormal or excessive fat accumulation in the adipose tissue. By adipose tissue, we mean this is the organ that stores fat in our body. So there's excessive fat accumulation in this adipose tissue to the extent that our health may be impaired. And we have to emphasize that it is a biological, a preventable, and a treatable disease. So obesity is a health crisis. The World Health Organization has already showed in a lot of their evidence bulletins that obesity is really a pandemic already. It is now rising the fastest in the lower and middle income countries. And obesity is especially prevalent in poorer and vulnerable communities. So, according to UNICEF, obesity affects more than 800 million adults worldwide. No? And in the local setting, in this epidemiology setting, 27 million Filipinos already have obesity. And more than a billion people globally is estimated to be living with obesity by 2030. So this is a really big disease-causing problem. In the Philippines, no? So this is a figure from the Department of Science and Technology Food and Nutrition Research Institute. This shows the trends in the prevalence of chronic energy deficiency and overweight and obesity among adults 20 years old and above. So this is the data from 1993 to 2018. As you can see in the blue line, we have patients with overweight and obesity, the prevalence of overweight and obesity. And in the red line, we have the prevalence of chronic energy deficiency. So we'll just pass through the figures on chronic energy deficiency because our topic for today is overweight and obesity. And as you can see, from 1993 up to 2018, there's a steady increase in the prevalence of overweight and obesity from 16.6%, it more than doubled to 37.2% in 2018. Therefore, 4 in 10 Filipino have overweight or obesity. This is another figure, an important figure as well in the management of overweight and obesity, the prevalence of high waist circumference among adult Filipinos 20 years old and above. As you can see, this is the figure for both males and females. It's a bit of a problem. It's a bit of a bigger problem for females. No? So the female prevalence of high waist circumference is depicted by the red line, and the male prevalence of high waist circumference is depicted by the black line. As you can see, there's a much higher prevalence of high waist circumference for females, and it actually increased from a figure of 17% in 2003 to 23.5% in 2018. So a rough estimate is 1 out of 5 women Filipinos have high waist circumference. No? However, this is actually a newer figure or a newer diagnostic criteria from the Lancet Commission on Diabetes and Endocrinology. This was published recently in March 2025, a year ago. So this actually highlights the need for that diagnosing obesity is beyond BMI. So as you can see on the left, we have to determine. So these are the diagnostic modalities that we can use. In terms of the diagnosis of obesity. So there is at least one body measurement of body size and BMI. If a body size is high and a BMI is high, we can actually diagnose obesity. So the second diagnostic criteria is at least 2 measurements of body size regardless of BMI. And finally, a direct body fat measurement such as DEXA scan. So the gold standard in diagnosing obesity is actually direct body fat measurement, using the DEXA scan. However, this is actually pricey. So we usually do not rely on these diagnostics, or we usually rely on the body size and the BMI for management or and diagnosis of obesity. So here are the approved or the recommended measurements of body size. So the commission actually defines 3 measurements of body size that can be used to confirm excess body fat. First is actually the waist circumference. So the waist circumference is the most studied among the 3 body size measurements. It actually differs per race. And for Caucasians, it's depicted, or it's actually pegged at 102 centimeters for men and at least 88 centimeters for women. And in Asians, it's much lower. The figure is much lower at least 90 centimeters for men and at least 80 centimeters for women. So why is this so? Because recent studies showed that Asians are actually at a much higher risk of having cardiovascular diseases at lower BMI and lower BMI, such that WHO had to particularly devise a separate criteria for Asians. So that's it for waist circumference. We also have the waist to hip ratio. So the cutoff for men is at least 0.9, and the cutoff for women is at least 0.85 to say that you have an excess or a high waist to hip ratio. And finally, we have the waist to height ratio, and a waist to height ratio of more than 0.5 for all races, both Caucasian and Asians, would constitute a positive measurement of excessive body size. However, we can actually skip these criteria if the excess body fat, or if the BMI is at least more than 40 kilograms per meter squared, and we can actually pragmatically assume that there is excess body fat with this level of BMI. So again, in the diagnosis of obesity, nowadays we usually rely not just on the BMI, we go beyond the BMI. We rely on body measurements, body size measurements, and BMI. Again, at least a one body measurement, body size measurement that is elevated, and an elevated BMI would actually tell us that the patient has obesity. Or there are at least 2 measurements of body size regardless of BMI. If these 2 measurements are high or elevated, we can diagnose obesity. How do we measure body mass index? So BMI is easily measured using the weight and height. We divide the weight by the square of the height. And there are a lot of online calculators that we can use to measure BMI. How about, before we go to the waist circumference and the other body size measurements, so here is a cutoff, or here are the criteria to say that the patient has overweight, obese class 1, obese class 2, is underweight, or has normal BMI. So it's different per race. As mentioned, there are risk differences between the different races, and at lower BMI levels, as mentioned, Asians are at a much higher risk of having cardiovascular disease than Caucasians, hence the lower cutoffs for Asians. So let's go through them one by one. Those who are underweight are considered to have a BMI of at least, or at most less than 18.5 kilograms per meter squared. Patients who have normal BMI, in Asians, it's 18.5 to 22.9. For Caucasians, it's 18.5 to 24.9. Those who have overweight, in Asians, it's 23 to 24.9. And those who are Caucasians, at 25 to 29.9 kilogram per meter squared. Let's go to obesity. Obese class 1, in Asians, it's at 25 to 29.9. And for Caucasians, it's 30 to 34.9. And finally, for obese class 2, Asians are considered to have obese class 2 if they have at least 30 kilograms per meter squared. And in Caucasians, it's at least 35 kilograms per meter squared. How do we measure waist circumference? So this is from the WHO STEPS protocol. So we a person is enjoined to stand straight with both feet together, and you have to feel for the last rib on your side, as in on the figure. It's depicted as number 2. And then you also have to palpate for your hip bone, the tip of your hip bone, the highest point of your hip bone, depicted as number 3 on the figure. And then you place the measuring tape between points 2 and 3. You're advised to inhale and exhale for 3 times and get the measurement after the 3rd cycle. So that's the waist circumference. Again, as a review, a waist circumference for Caucasians of at least 102 centimeters for men and at least 88 centimeters for women are considered elevated. And for Asians, it's at least 90 centimeters for men and at least 80 centimeters for women. So let's go to the waist to hip ratio. So we've already gone through the waist circumference. How about the hip circumference? So simply you just have to place the measuring tape around the widest circumference of your hip and you get the measurement. So again, as mentioned, waist circumference is a ratio. So you divide the waist circumference by the hip circumference. And the ratio that you get is the waist to hip ratio. So a ratio of more than 0.9 for men and more than 0.85 for women is considered elevated. So let's go to the effects of obesity on health and well-being. So as mentioned, obesity is a disease. It's a biological entity. And it actually causes a lot of complications. It's not just diabetes, it's not just hypertension, it's not just heart disease, which are the most commonly attributed complications or effects of obesity in our health. Obesity can also cause stroke and dementia. It can also cause cancer, such as uterine, breast, prostate, and colon cancer. Commonly, it also causes dyslipidemia or high cholesterol. It can also cause gallstones. Nowadays, there's an increasing evidence that it also causes chronic kidney disease. It causes fatty liver and cirrhosis. It causes sleep apnea, obstructive sleep apnea. So this is usually diagnosed, or this is usually screened when patients would actually complain of non-restful sleep with a lot of snoring at night. So patients with obesity can also have an increased risk for infertility, pregnancy loss. Of course, polycystic ovary syndrome is much severe if there is obesity as well. Patients with obesity complain a lot of joint pains, especially knee and hip osteoarthritis. They can also have increased risk for gouty arthritis, as well as depression. With increased risk of depression and other psychiatric disorders, there's an increased risk of discrimination and social stigma. In the pulmonary system, there's an increased risk for complications for asthma. And of course, with all these plethora of risk factors and complications in adverse events from obesity, there's an increased risk for mortality in patients with obesity as the BMI actually and the waist circumference increases. How do we manage our weight properly? The ADA Professional Practice Committee for Obesity recommends 4 pillars for weight management, namely proper diet and caloric restriction, regular physical activity, medical and or surgical management, and of course, a regular consult with your licensed healthcare providers. So before we go through the pillars of weight management, we have to define first an individualized weight loss goal. As mentioned, goals should be individualized, but we should target at least a 5% weight loss or a minimum of 1 pound per week to be able to affect or to be able to provide the necessary benefits in patients, especially in patients with comorbidities or diseases such as hypertension, diabetes, dyslipidemia, and other aforementioned adverse events of obesity. However, this table would actually highlight the weight loss goals that are clinically important for the respective diseases. So a weight loss goal of 2 to 3% would actually lead to an improvement in the blood glucose and initial cholesterol improvements. So as low as 2 to 3%, there is actually a noticeable change, especially in your laboratory test results. But the most common or the commonly clinically meaningful threshold is at least 5% because this actually reduces diabetes risk, it improves blood pressure, it reduces knee joint pain, and improves sleep apnea and lowers inflammation caused by obesity. A weight loss goal of more than 10% significantly reduces heart disease risk, it increases the good cholesterol, it reduces fatty liver, and it improves symptoms of polycystic ovary syndrome. If we have an initial clinically meaningful threshold, we also have a gold standard for long-term health in terms of weight loss goal. And a weight loss goal of at least 10 to 15% drastically reduces diabetes, improves sleep apnea, lowers cancer risks, and improves sexual function. And finally, a weight loss goal of more than 15% actually would provide disease modification and reversal. There is a higher rate of diabetes remission, maximum reduction in cardiovascular risk, and there is improved longevity or a decrease in mortality rate. Let's briefly talk about diabetes remission. It's not really a cure for diabetes. It's just control of diabetes without medications, meaning it's just from a diet, physical activity, and or medications that lower your weight, but not really medications that lower your blood sugar. Proper diet and caloric restriction. This is actually a recommendation from the 2018 Endocrine Society guidelines. So a diet or a calorie restriction of a reduction in at least more than 500k calories, kilocalories per day would actually be sufficient in causing weight loss. And the typical macronutrient composition is as follows. So, however, this should be individualized for patients with obesity. So it's really important for you to be guided by a registered nutritionist dietitian. In terms of weight loss maintenance, we would recommend still a hypocaloric diet to maintain the reduced body weight. This is the recommendation from the FNRI. This is the Filipino Pyramid Food Guide for today's lifestyle. So we usually would recommend, of course, drinking water the most, and then eat most of rice, root crops, corn, noodles, bread, cereals. Eat more of vegetables, green salads, fruits, or juices, and we have to eat some to little of high-fat meat, especially the fish, especially poultry, processed foods, etc. So here's another guide. So in terms of caloric restriction, we usually do portion sizing, and we usually do we usually use the exchange system. So here is actually a quick guide that you can use in terms of portion sizing, or in terms of limiting the calories that you take in every day. Shown in the next few slides are selected exchanges of carbohydrate containing food groups. So this is a slide depicting selected vegetable exchanges. So there are actually vegetables that have a small amount of carbohydrates, but there are some also who have negligible calories, and this should be included in the meals as much as desired, because they do not provide that much calories and they do not provide that much carbohydrate. This is from the Food and Nutrition Research Institute Food Exchange List. So you can actually purchase this in the Food and Nutrition Research Institute office, no? And this is a good guide for everyone, not just for those who want to really lose weight or who want to really control their intake, especially for those with hypertension, diabetes, dyslipidemia, or high cholesterol levels in the blood, or those with heart disease. But in general, in the general population, this can be very useful for those who want to really maintain their weight and who want to be healthy. So these are some of the exchanges of fruits. And one exchange of fruit is equal to 10 grams of carbohydrates. These are selected milk exchanges. We have 3 subgroups for milk exchanges. We have the whole milk, the low fat, and the non-fat. Of course, the non-fat constitute 0 gram of fat, no? But all of these milk groups would contain a fixed amount of carbohydrates and protein. 12 grams of carbohydrates and 8 grams of protein, with varying fats depending on if the milk is whole milk, low fat, or non-fat. These are some selected rice exchanges. So these are usually found in the normal Filipino diet, no? So we have 3 subgroups for this rice exchanges. We have rice A, rice B, rice C. Again, we have to emphasize that these are just some guides. It's still important for you to consult your dietitian or your nutritionist or medical nutrition provider to be able to assess you nutritionally and for you to have an effective dietary counseling and intervention. Again, these are selected sugar exchanges, and one exchange of sugar is 5 grams of carbohydrates. Second, we go to regular physical activity. So we've covered proper diet or proper diet and caloric restriction. We now go to the second pillar, which is regular physical activity. And the recommendation is for you to have regular physical activity, both cardiovascular and resistance training of at least 30 minutes per day, 5 to 7 days a week of moderate to high intensity aerobic exercises with resistance training to preserve muscle mass. So in this slide, I want to emphasize that resistance training is also important, not just the aerobic exercises, for you to maintain your muscle mass. Because when we lose weight, it's important to remember that we do not only lose fat mass, we also lose our lean mass, which includes muscle mass. And in order to preserve, or in order to maintain the normal muscle mass in the body, it's also important to couple your protein intake with, of course, resistance training. Again, this is the 2018 Endocrine Society recommendation. No? So aside from dietary prescription, they also advise on the amount of physical activity that we can do per week. In this recommendation, of course, it's recommended for you to do physical activities of at least 180 minutes per week of moderately vigorous aerobic activity with strength training in order to promote weight loss. But it has to increase gradually for you to maintain what you lost. So the recommendation for weight loss maintenance is physical activity of 200 to 300 minutes per week of moderately vigorous aerobic activity with intermittent strength training as well. We now go to the medical and surgical treatment. No? So in order for you to qualify for the medical and surgical treatment, we have a set amount of criteria. So this is actually from the Asia Oceania recommendation together with the CDC recommendation. No? So they actually summarize the recommendations from the different governing bodies and policy makers. So those with a BMI of at least 27 kilograms per meter squared with at least one illness or one comorbidity is actually approved for the use of weight loss medications, and a BMI of at least 30 kilograms per meter squared, even without comorbidities such as type 2 diabetes, heart disease, hypertension, hyperlipidemia or high blood cholesterol, obstructive sleep apnea, fatty liver disease, osteoarthritis, and major depression. Even without these comorbidities, you are able to, or you are approved, or you are advised to use weight loss medication on top of course, the foundation of regular physical activity and caloric restriction. So it has to be a multidisciplinary involvement. No? So not just the medications, not just the prescriptions from our physicians, but we also have to involve our nutritionists, dietitians, our fitness coaches, our trainers, for you to have a meaningful weight loss journey. So yeah. So again, the magic number is 27 with at least one illness and at least 30 kilograms even without illness. So again, this is an adjunct to an energy deficient or a caloric restriction, increased physical activity, and behavioral modification. These are the FDA-approved medications that are available here in the country. So in terms of tablets, we have the phentermine-topiramate combination, the naltrexone bupropion combination, and orlistat. And for the injectables, we have the GLP-1 agonist, the famous or the much sought after injectables, the GLP-1 agonist, and right now the newest kid on the block, the GLP-GIP combination, which is the tirzepatide. So liraglutide and semaglutide. Liraglutide, the brand name is Saxenda, and semaglutide, the brand name Ozempic, or in other countries it's Wegovy. These are GLP-1 agonists, single acting GLP-1 agonist. However, tirzepatide, again, as I've mentioned, the newest kid on the block, it's a combination GLP-1 agonist and a GIP. So it acts on two receptors in the body to promote weight loss. So later on, we're going to discuss the mechanisms of the weight loss, the usual way to start, and the tips on how to prevent adverse events from these medications. So briefly, let's go through the different FDA-approved medications. This won't be too technical, but rather this is just meant for you to be aware of the options that are available, and of course the usual adverse events, the usual starting dose and the maximum dose that you can be on when you decide to start the medication with your healthcare provider. So let's start with orlistat. By the way, the numbers or the percentage that you see beside the names of the drugs, these are the mean or the average placebo-reduced weight loss. So this is purely from the effect, purely from the medication, with of course lifestyle management such as caloric restriction and increased physical activity. So for orlistat, we have a mean weight loss of 3.1%. And the initial dose, so this is an oral drug. The downside is that it should be taken 3 times a day. The mechanism is that it actually inhibits your stomach and your gut from absorbing the fat content of your food. So the result is oily fecal spotting. And in some patients, they usually complain of explosive diarrhea because of the non-absorbed fat content from the food, and they usually complain of flatulence, increased fecal urgency, and increased defecation. So second is the phentermine-topiramate combination. So it can cause mean weight loss of 8.8%, a big weight loss goal. So it's more than the 5% clinically meaningful goal. So historically, this is one of the go-to medications in terms of adjunctive weight loss over our caloric restriction and physical activity. And we usually start it at the lowest dose, and we adjust the doses as we go along. If we can't reach the goal, the weight loss goal that we set with our patients, we can increase to the highest, which is 50 milligrams by 92 milligrams daily. But we have to be careful because this combination causes some of these adverse events, especially paresthesias, dry mouth, headache, constipation, insomnia, altered taste, and cognitive impairment. So the usual tips on how to avoid this is to drink lots of fluids as well, to alleviate the dry mouth. No, but of course we have to reduce the dose if there is an increasing amount of adverse events or increasing severity of adverse events for patients. The third oral weight loss drug is the naltrexone bupropion. It causes around 4.8% mean weight loss. No? So depicted in this table is the initial dose and the schedule for dose escalation and the maximum dose. Usually it causes symptoms such as nausea, constipation, vomiting, headache, dizziness, dry mouth, and insomnia. And the usual tips on prevention of adverse events from phentermine to pyramid applied to naltrexone bupropion as well. Now comes the slide on the injectable therapy. These are the, again, incretin based or the GLP-1 based therapy. These are injectables and they vary by the frequency of administration. So the first one that was actually available in the country was liraglutide, and it causes a mean weight loss of 4.5%. The downside of this particular injectable is that it's given daily. From week 1, we usually start with the lowest dose, and we increase by an increment of 0.6 milligram weekly until we reach the maximum dose of 3 milligram subcutaneously daily. Similar to the other, to the next GLP-1 and GLP-1 medications, this cause nausea, vomiting, diarrhea, constipation, and dyspepsia. Among these, the most common is nausea and vomiting. So later we will talk about how to prevent this, but let's first go through the other combination. The other medications rather. So semaglutide or Ozempic or Wegovy causes a weight loss of around 12%, 11.9%. Again, we usually start at the lowest dose. Later on, we'll tell you why we usually start at the lowest dose first, and we do increment increases by 0.25 up until 1 milligram, and then we start or we increase to 1.7 and finally to 2.4 milligram, which is the highest dose currently approved for weight loss. However, the downside of this drug is that the highest dose that is available in the country is just 1 milligram. So we're still waiting for the FDA approval for the 1.7 milligram pen and the 2.4 milligram pen. The advantage of this drug over liraglutide is it's given weekly, and it has a higher weight loss provision, and it can actually also help with cardiovascular diseases as well as control of diabetes, similar to liraglutide. Okay, and finally we have tirzepatide. So this is the newest FDA-approved injectable weight loss medication that is currently available in the country. We again start with the lowest dose at 2.5 milligram, and we do a monthly increment of 2.5 milligram until the highest dose of 15 milligrams. So mind you, we do not necessarily need to reach the 15 milligram once weekly dose. If you've already reached our weight loss goal, or if we are using this for diabetes control, if we already reached our diabetes and obesity goals, then you may opt not to, of course, increase the dose to as high as 15 milligrams. So as mentioned, these are the adverse events, and we usually start our injectable doses to the lowest dose for us to be able to avoid, or for us to be able to reduce the incidence of these adverse events, no? Because going for the higher doses and adjusting the doses quickly would actually increase the risk for having these gastrointestinal adverse events. Other tips to reduce the adverse events for the use of these injectables is to avoid spicy food, to avoid high-fat food, the oily ones, no, and of course to drink lots of fluids still, because again, dehydration can also increase the nausea and vomiting, and of course the other gastrointestinal adverse events. Okay. Aside from medical treatment, we also have surgical treatment of obesity. No? So we have bariatric surgery, and these are the ways on how to go about with bariatric surgery. And I think the most commonly used methods of bariatric surgery is the Roux-en-Y, the figure A, and of course figure C, the sleeve gastrectomy. This bariatric surgery can cause up to 30% weight loss in most studies, so much higher than those achieved by the currently approved injectable medications. But of course, this is a much more invasive procedure, and it doesn't and it's not free, of course, of complications. So usually when we prescribe or when we advise patients to undergo this, they have to go through a lot of tests first and a lot of consultations with a multidisciplinary team for us to be able to do this successfully. Okay. And finally, the final pillar of the weight loss management is a regular consult, of course, with your healthcare provider. As mentioned, it has to be composed of these specializations. No? So it has to be a multidisciplinary team comprising of your primary care physician, your endocrinologist, your medical nutrition physicians, your dietitians, your nurse practitioner or your nurse, your behaviorist, your surgeon if you decide to undergo surgery, of course psychiatry, because weight loss and of course the methods that come with it might cause some significant distress in our patients. And as mentioned, obesity can be complicated by psychiatric disorders such as depression, anxiety, and the like. Of course, in terms of dispensing medications, we have the pharmacists, gastroenterologists, and other, of course, specialists. So I think that's the last slide. Thank you very much for your participation and for watching. I hope that I've provided you with some information to start your weight loss journey. So thank you very much again.